Okay, so RHPT is a project supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. Janine Myers is the RHPT project officer. And then our purpose, so for RHPT, our purpose is designed to help strengthen organizational foundation in the key elements of value-based care, including efficiency, quality, patient experience, and safety of care. Our goal in RHPT is to guide small rural hospitals and certified rural health clinics not currently participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a health system focused on value. And now I'd like to welcome today's speaker, Madeline Wilson, Quality and Patient Safety Advisor from the Indiana Hospital Association. After serving over 30 years in the nursing field in acute and ambulatory settings in quality, risk, regulatory, and patient safety, Madeline decided to take her passion for zero harm to the next level by using her skills in change management, both at the state and national level. She assists hospitals in harm reduction with performance improvement initiatives, educational resources, and culture of safety coaching. Also serving as the health equity lead for the Indiana Hospital Association, Madeline has assisted hospitals with the development of systems to track social determinants of health through Z-code tracking to better identify the needs of communities. She's a member of the Indiana Sexual Violence Prevention Council and has been trained in the Indiana Trafficking Victims Assistance Program. Madeline also holds a master's degree in nursing with a focus on healthcare policy and advocates at both the patient and hospital level. Thank you so much for speaking today, Madeline. We're really excited about what you have to share. And now I'm going to stop sharing and hand things off to you.
All righty. Thank you so much for that intro, Molly. Let's go ahead and get this shared. All righty. Well, good afternoon, everybody. So glad to have an opportunity to share a little bit of my passion with you. Just to give a little bit of background on what we'll talk about today. You know, health equity requirements have been building over the last several years, especially following the pandemic, as you all are pretty much acquainted with. In 2015, CMS introduced the first ever equity plan for improving quality in Medicare. And this plan has really grown exponentially. And what started out as just collecting race, ethnicity, and language data has now progressed, into the collection of social drivers of health data, becoming mandatory for hospitals through various regulatory programs, and also very much integrated into the rural health clinics and medical practices as well. In Indiana, we began this social driver of health program journey about 6 years ago, which started off with 14 rural hospitals. And the initiative has really proved to be challenging at times. So in this webinar, I really hope that you can learn a little bit about the various social drivers of health and their patient, the impact on patient outcomes. And also, I'm going to share Indiana's path on the initiatives and the understanding of this whole program. So our objectives today are to differentiate between social drivers of health, health equity, health equality, and health disparities, to recognize how social drivers of health influence health outcomes and the roles that hospitals and health systems can play in identifying gaps in care, and to interpret how the history and the future expectation of our regulatory bodies, which include CMS and the payers, what are their expectations on identification of social drivers of health? So hopefully, at the end of this presentation, you might be able to change your polling questions to be a little bit more confident. Let's first start with the definitions. So social determinants of health are the conditions in the environments where people are born and they live, learn, work, play, where they worship, and where they age. And these determinants really affect a wide range of health functioning and quality of life outcomes and risks. And they can really have a major impact on people's health and well-being. They also contribute to a wide range of health disparities and inequities. And we can really kind of put these into five domains. The first one is healthcare access and quality, then education and access, economic stability, social and community context, and the neighborhood and built environment. That's really an important one that sometimes we don't really kind of put in our work categories. When you look at these five domains, we can see that there are health drivers that fall under each one specifically. When you look at healthcare access and quality, that includes health coverage, provider availability, which a lot of rural areas are really struggling with right now. Provider linguistics and cultural competency. I hear a lot from our hospitals with some language struggles and barriers. Quality of care at healthcare facilities. The second category, education, that includes literacy, language, early childhood education, vocational training, and higher education. Then in the economic stability category, you have employment, you have income, expenses, debt, medical bills, and support for all of those. For community and social context, which is social integration into your community, what kind of support systems are there? Is there stress in that community? Is there exposure to violence? And is there trauma where people live? And then lastly, as I said, the neighborhood and built environment. That includes housing situations, transportation, big one in rural communities, safety. Are there parks? Are there places to walk for kids to play? And we also will see a little bit here coming up what the influence of your zip code is. So each and every one of these drivers really has an impact on health outcomes, on mortality, and even on functional limitations. When we think of the impact part of these societal factors, only 20% of an individual's health is actually tied to clinical care that healthcare facilities provide. And so that also includes the access to care and the quality of those services. The physical environment, social drivers, and the behavioral factors drive 80% of a person's health outcomes. So, we're really accustomed to treating symptoms, right, of patients. But, oftentimes we really don't look closely enough to really see what external factor could be standing in the way of people achieving those optimal health outcomes. So if health systems are really committed to improving the health and well-being for their patients in their community, we really need to think outside the walls of a hospital. And it's really important to uncover what are those systemic consequences of those health inequities that we see. So, here we go about uncovering these inequities without infringing upon somebody's personal space. It's really important too, and to include that language when we talk to them about these social drivers. And, this is a challenge for people right now because they don't know how to have those personal conversations. It's easy to ask somebody, are you diabetic? What kind of medical conditions you have? But it's not easy to say, do you feel safe at home? Do you have enough food? And so, we're really kind of having to reframe how we talk to our patients. I put this quote in here because I thought it was really good. It was actually in a recent health affairs blog that they stated, now more than ever, it is crucial that we use language that speaks to the reality of people's lives and illuminates rather than obscures our shared understanding of and responsibility to act on all the factors that drive health. Illuminates rather than obscures. So I want to change up how I talk a little bit here going forward now. So the term social determinants of health has now been replaced with the term social drivers of health. The reason for this is when you think of the word determinants, really that suggests that really nothing can be done to change our health fate. Basically, that's just the way it is, right? But when we say that something actually drives an outcome, we're saying that that factor can be overcome and we can change those negative influencers, right? A driver is something that, leads you to, what you do. Maybe it's smoking, right? And so we want to get rid of that determinant. We don't want it to be, a label that's placed on somebody. So there's many factors that contribute to health and the conditions that shape healthy communities. There's societal and political structures, systems and policies. Those are all big influencers. And in many cases, they do create environments that determine how long and how well people live. For the folks that I work with in Indiana, I like to use resources that show them what their communities look like in terms of health outcomes and rankings. A lot of people aren't aware that there is some data out there, but one of my go-to places is the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. They collaborated to develop this report that shows how each state's counties ranked on their health outcomes and health factors. And you can go to this site and type in your state to get all of your specific information as well. If you haven't been there.
You want to run in and get some donuts for you guys
somebody,
this afternoon?
Somebody needs to put their mute on. Thank you. But donuts do sound good. Going back to the report, for the health factors, that actually includes behaviors in your community, such as tobacco use, diet and exercise, alcohol and drug use, clinical care, social and economic factors like education, employment, family and social support, community safety, and a healthy physical environment. So you see all of those things that I showed you in those 5 domains are included in there. And looking at the health rankings report for Indiana, this is just a snapshot of our state. Where you see the more pinkish, purplish colors on those individual counties, those are actually the least healthy counties that is compared to other states in the US. Some people are really kind of surprised when they see this. So I want to kind of give you an example here. One of our counties in Indiana, Stark County, where the arrow is, falls into one of the least healthy counties in the US. This county is considered rural. And 100% of the population lives in a low population density area. So not very populated. When you look at the bar graph on the upper right-hand corner, you can see this more clearly. And below that, you can see the percentage for each one of the health behaviors and so on. So it kind of gives you an idea of what are those health factors impacting these outcomes. It's very interesting to see this data, and it's very beneficial when you're looking at your own data and in developing some performance improvement strategies. There's also a map for the health outcomes, which tells us how long people live on average within a specific community, and also how much poor physical and mental health people experience in these communities while they're alive and living in those communities. So going back to Stark County, here you can see that they are really faring worse than the average county in Indiana for health outcomes and worse than the average county in the nation. Their life expectancy is 5.2 years shorter than the nation, and it's 3.2 years shorter than the state. Now, the interesting thing about that is just one county over, which is Porter County, they have a life expectancy of 77.5 years. That's actually 5.1 more years than Stark County, their next door neighbor. I will point out Porter County is considered just about 27% rural, so moves it a little bit more out of that low density population, but they're neighbors, right? I mean, that's a big difference. And so the reason why I point this out, I think it's really important to know what are your counties experiencing, and why it's good to know that. It's because we are going to now talk about Z codes, and those are actually some data pieces that you can collect to see how they fit on those outcomes. So, going back to looking at these data points, when you see things like that, you need to ask, what needs does this population have? What does Stark County need to get healthier? If the outcomes are so vastly different, why? Are we giving fair and equal treatment to them as a collective state at the resources we offer? And so with that being said, what is equality? Well, equality is when everyone gets the same, regardless if it's needed for them or right for them. So everybody gets the same amount of transportation fund, maybe housing funds, what have you. But when you look at equity, equity is when everyone gets what they need. So you have to understand the barriers, you have to understand the circumstances, and you have to know what conditions that population in those counties, what are they experiencing? So when we offer these services to them, we need to know these very important things. These definitions are really important to know when you consider how patients traverse through healthcare in or near the communities that you all serve as well. Is it enough to say that there are free resources for folks who need assistance with such things as food or medications, but we really don't consider the means by which they would get to the food or the medications or where it's located? Are we considering those cultural differences that we experience all across our states? Are we just making it a one-size-fits-all thing? How do we find those answers? That's the million-dollar question. So, data. Data can tell a story, but if the data is incomplete or unaligned, the story is also incomplete. Data can help us to understand what people's greatest needs are. It can also link with that race and ethnicity and sexual orientation and language barriers. To really advance health equity, we really must improve on collecting that health equity data. It's not easy to do, right? But, as CMS started this conversation quite a while ago, and now the pace is picking up on what we all must do to fill those gaps, we really need to understand, how did we get here and what is going to be required of us going forward. So let's take a look at the history of CMS's plan for health equity, and hopefully this will fill in some of the blanks for you. In 2015, CMS introduced the first ever equity plan for improving quality in Medicare. This plan provided an action-oriented, results-driven approach for advancing health equity by working on improving the quality of care provided just to that minority and other underserved Medicare beneficiaries. So they just used the Medicare group. They zeroed in their focus around these 6 high impact priority areas that you see on the slide here that incorporated both the community and the systems level approach to trying to achieve health equity. If you look at the very first priority, it is to expand the collection, reporting, analysis of standardized data, which many organizations right now, they're just starting this, even though this came out in 2015. When they designed this plan, it was intended to be a 6-year plan. And I can tell you, after working on this for the last 6 years with my small group of hospitals that I started with, I really can understand why this was a 6-year plan. It's definitely not something that is accomplished very easily. In 2016, they began the introduction of improving the collection of demographic patient data with what is called the real data, and that is the race, ethnicity, and language data. Then they added on to that the sexual orientation data and then the disability status. So this was just the beginning of this data that we would be asked to collect. CMS engaged with a broad range of programs and many stakeholder, holders all across the agencies because they really wanted to understand where in the journey to address health equity and to discern, what solutions would be most valuable for people. So early in year 1, CMS worked with the QIN, QIOs, and with the HENs, and with the Transforming Clinical Practice Initiative awardees to help them understand where disparities are called out in their current statements of work and to identify areas of overlap in other programs. So not to be duplicative, but kind of just to find a way for incorporation of these enhanced measures. They also worked with other groups and started embedding health equity into the nursing focus. Then in 2019, fast forward a little bit, CMS identified and developed what's called the Standardized Patient Assessment Data Elements, or SPADES. And that was to assess social determinants of health. They called it determinants of health then. And they embedded these data elements into the post-acute quality reporting programs. And the intention was to start collecting that data in 2022. But unfortunately, it was somewhat delayed due to the pandemic. And so everything's kind of been delayed a little bit, but now things are ramping back up. But when they did do this, this policy really changed the Medicare's prospective payment system rules. And so you'll see that it makes collection of social drivers of health data part of the required standardized patient assessments that are introduced in the post-acute care settings. So they were the first ones to really start receiving requirements for collecting this data. And this group of people extends to the long-term care hospitals, the skilled nursing facilities, the rehab facilities, and home health agency. The additional SPADES, then they added on the race, ethnicity, and language data as well. And then they included health literacy, transportation, and social isolation, which is a big one that we see now. So collecting this data allows CMS to really inform more of a provider understanding and better facilitate coordinated care across the continuum. At the most recent CMS Quality Conference, every single breakout session had some element in it about health equity and social driver of health. So it was in 2022 that they developed a new framework. And so in in 2022, it was consistent with the Department of Health and Human Services Healthy People 2030 framework that CMS recognizes that addressing health and healthcare disparities and achieving health equity really should underpin efforts to focus attention and drive actions as one of our nation's top priorities. So it really moved up that ladder of importance. In 2022, they established the framework for health equity, which is improved upon from that 2015 framework that only focused just on that small Medicare community. Now it encompasses all CMS-supported programs. And they took the 6 high impact priority areas from 15 and they regrouped them in to these 5 that you see here, which does include expanding the collection analysis and standardized data, which is what we're going to focus on a little bit more here in just a minute. And I also wanted to note on priority 4, which is the CMS health equity in the health equity framework, which is advanced language access, health literacy, and the provision of culturally tailored services. You know, it's really imperative to leverage partnerships to bring the most pertinent information directly to the communities who need it the most. And we really need to make sure that we're able to deliver that in a way that resonates with that population. And this is probably one of the greatest challenges that we see in Indiana as we see multiple areas of unique populations. And we really struggle with how to get the resources in the most appropriate way to them. And so, you know, I go back to the health equality and the health equity. You know, we need to make sure that we're looking at health equality and health equity in the event that what we are giving is not a one-size-fits-all, but that it is able to be used by everybody in your community. So now let's talk about how we acknowledge the social drivers of health. Let's go back to that 4-letter word data, specifically something called Z codes. I know that many of you know this definition already, but for those that do not, Z codes are a subset of the ICD-10 diagnosis codes that represent the factors that influence that health status, and they are coded as a non-medical diagnosis. There are hundreds of Z codes in the ICD-10 coding manual, but this category is only specific to the social drivers of health. And that's just those categories that are found in Z55 through 65. In this slide here, you can see here are the categories of the code. And as you can see, they're not medical conditions. Within each one of these categories, though, there are additional codes that fall like after the decimal point. So if you see Z55, there's like a Z55.1, a 0.2. It is very interesting that we started off with just this small group, but each year more specificity is occurring with these codes. And some of these main categories, their names are even changing as CMS is looking to get drilled down a little bit, as I said, more specific. Right now, there are over 100 Z codes that fall between Z55 and Z65. And when you think about a lot of the stories that healthcare members hear from their patients, that's really a patient's Z code story. In reading some of these examples that you have here, we can see that they are really factors that impact that patient from possibly, you know, reaching the best health outcome that they can. These codes actually link to that slide that I showed you, those 5 categories. They actually, they link to those categories. And CMS is beginning to see that we really will continue to struggle to have a healthier population if we don't look at those external barriers. But these codes traditionally have not been codes that have been captured by our coders to kind of help tell that story. And so that means that we really need to change some of our workflows to get that information. Developing the Z code reporting process is generally sourced from administrative claims, and it really requires guidance so that there's a specific place in the record that the coders know where to abstract that data from. It's very challenging. The phrase needle in a haystack really applies when coders are trying to develop this process. It also requires a multidisciplinary team to understand the workflow, as it's a big change in a normal coding process. And you also need to have an analytics team involved to kind of help establish where that information can be positioned in your EMR. And education. Coders and other staff members need to know that a checkbox does not constitute coding for a social driver of health. There needs to be documentation that supports that need and what impact it has on that patient. So you might need to have some clinical documentation improvement specialists, get them up to speed and get them some education so they help to allow better documentation. And as I said, this is not an overnight process. It took every bit of 5 years for our group of 14 hospitals in that pilot project to get to a place where this is just part of their workflow. If you haven't seen this resource before by the American Hospital Association, it was back in 2018 that they helped to make a change from provider-only documentation, and they actually moved that and provided this form that I say everybody needs to print this off and have it handy. It talks about the coding rule being changed so that coders can code off of documentation from another healthcare clinician, such as a nurse's documentation, a social worker, a community health worker, a physician's assistant. It does not necessarily have to be right from a doctor's documentation. So this really played a big role in coders being able to understand where did they find this information to code, because before they just went to the physician's notes. Now it could be anywhere in the record. So that's why a workflow is so important. And as I said, here's just a couple of bullet points to know that, coding professionals can utilize that documentation, maybe in the social worker's notes. If you have navigators in that as well, or maybe you could do some type of link in your EMR that brings that all together. Some of the larger systems like Epic and Cerner are currently they do have some workflows that kind of merge and put things on maybe the patient's progress list. But I do want to point out here, anywhere you see in the slide deck anything that's blue, that is a link for you to click on. It's really important to go to the CMS website and keep abreast of coding updates, because in this space of social drivers of health and health equity, there are changes coming at us right and left. And it's not just annually anymore. So why are Z codes so important? The more specific medical records can be with these type of codes, which often reflect those social drivers, the better healthcare providers can identify those barriers, that might be in place that they can't get good treatment for. These codes also help to document situations that can protect providers legally. An example of that, if a patient's condition worsens due to non-compliance, having these codes documented can really show that, the provider did their due diligence. And so, as I said, as the focus is increased on social drivers, so have the number of codes. Until recently, each October is when the coding rules were updated. But now that's changed, and now they do updates every October to April. So very interestingly enough, last year, there were 114 Z codes for social drivers of health, but now there's only 107. But the reason why there's only 107 is because they started categorizing them differently. And I will tell you, that's been a bit of a challenge for me on the back end, who's helping hospitals capture this Z code data, because if a code change and the language doesn't change in our data collection tool, then they might not be seeing true collected Z codes. So that has been a little bit of a challenge. Screening tools, many of the EMRs have their own screening tools built into these programs. And as I said, it's been very helpful to link them with those social drivers of health. There are many tools out there, and CMS does not mandate that you have one specific tool. Basically, they just say you have to have a tool that addresses these 5 areas: housing, transportation, food security, personal safety, and the ability for people to pay for utilities. So as long as your social screening tool includes questions that address these areas, then you will be good to go. You can also, I don't always recommend this, but some people have to do this right now. You can also give a paper tool to your patients to fill out. And coders can actually use that information along with documentation in the record for that positive response to code off of that as well. I found this interesting study by Deloitte. It was conducted in 2017 and then repeated in 2021. And in those that 4 years, in 2017, it didn't change much. 88% of the survey respondents stated that they screened for social drivers, but only 33% reported that they actually connected people to resources. So they repeated it in 2021, and it showed that 79% screened and 35% connected people to resources. And looking at this and what I see in Indiana, this is really not unlike what we've seen. And a lot of people, that I work with on our projects have said, Madeline, we don't want to screen because we don't have the resources to give to our patients, and we feel we might be at risk by not giving them resources. And I encourage you to really go out there and take a look at your state resources. We have Indiana 211, and many states do have a 211, which is a place that anybody could go to and get some type of resources. So it's not really caring for your patient if you ignore those health-related social needs, right? And so team building is so important. You need to bring in your hospital leadership. They have to support all the workflows that go along with it. Your clinical staff needs to know why this is important. Your coders need to know the rules behind it. They need to be educated, and they need a good work path. Your IT teams to help you design systems to capture this data, and your people who will be the ones responsible for doing this screening. So building that team is imperative to get this work started off in your facilities. So I want to just kind of share with you a little bit really quickly about some of the things we've been doing in Indiana. We do build our foundation on the Healthy People 2030 goals. And if you have followed Healthy People goals, you will see that the difference between Healthy People 2020 and 2030 is these, health equity language rose right up to the top. And so it now is embedded in a lot of the goals everywhere going forward. And so we have now embedded that work in several of our grants. We do a small hospital improvement, rural hospital improvement grant, or SHIP, that I know a lot of you are very familiar with. That was our first grant where we actually took those 14 hospitals, and we piloted that program to build these processes to capture Z codes and do social needs screening. We then moved into a grant with all of our delivering facilities in Indiana, so they're now capturing that data. We've integrated it into a CDC grant with the COPD population and looking at the link with readmissions and COVID involvement. And also in our, it's called our HQuick grant that also has one component that we engage with our patient and family engagement councils. We developed this dashboard where all of our hospitals can go in and they could see how many Z codes they're capturing and what are those codes. Very important for them to know how they can do quality improvement. And this is just a snapshot of how we have improved over the last several years as well. I will tell you, we started with 0.6% of our hospital claims had any kind of Z code on it. We are at, right now, I just got the fourth quarter of 2023. We're at 1.2%, which is the teeny tiny percentage, but it has doubled since we started this. And we improved each year in capturing this data, even through the pandemic. Long way to go, but I think that 2024 will be a good year to really see some vast improvements. And remember this slide where we see the health factors that are contributing to our state of Indiana's poor health. We use this information from Robert Wood Johnson and correlate it to what we're seeing with our data as well. And what we're doing with that is we can take this information to our state's policymakers and we can say, look at Stark County. They have a terrible transportation deficit here, or a food insecurity, deficit here. We need to allocate more funding towards these counties that we can show data for that's having these struggles. So keep that in mind as you start collecting this data. This is how you get resources. So what about current and future expectations? Well, I will tell you, it's like moving this rock. It's been hard. It's been challenging. We have run into barriers with EMRs. We have run into barriers with people not understanding the work. We have had a lot of challenges with staffing. Who is going to do this work? And I will tell you, because I've had hospitals, engaging in this work for a while, now they're trying to look at some creative ways to do this. Maybe it's a registration clerk that's asking these questions or providing the social driver of health assessment questions as they're doing registration for people. And it puts a flag so that when that patient sees the provider, that provider sees upfront and personal that there's a need. But digging in a little bit deeper here, once again, I provided some links here just to give you a taste of this. There's been a lot of changes. In 2022, CMS announced some changes in their ACO models and incorporated, health equity and screening. In the CMS 2020 through inpatient final rule actually became mandatory that hospitals need to screen. It's a little bit different. There are two measures. One is a hospital's commitment to establishing that culture of equity. The other is to actually report how many patients are eligible to be screened and how many actually do have social needs. So when I think of the Z code, it's what came first, the Z code, the chicken or the egg. It's also for you that are a part of your MB-QUIP projects. Next year, it is one of the standard measures that you will be required to ask for. If you're a joint commission facility, you will now receive a condition of participation if you do not do some type of screening. And CMS is telling us there's more to come. So this was in the 2024 rule saying that they plan on doing more. There are opportunities now that we have out there actually that you can get more reimbursement. Homelessness now is considered a comorbid condition. If it's added onto your DRG, you can get more money for that. Hospital value-based purchasing programs, it's moving forward in that. Medicaid, I know I'm going through these really quick, but Medicaid is also trying to establish putting this in as with pay for performance. Why that's important to Indiana, we have a very high population in pockets of Medicaid, and so we really need to start working with that population and make sure we're capturing this data. Indiana actually adopted a 12-month postpartum coverage for our Medicare, our Medicaid population. We have 42% of our moms are on Medicaid. Anthem also is incorporating some health equity support. You can go here and read more about it. There are multiple payers that now incorporate it as well. And so you can just go out there and you can see on what's been optional. There's now incentives being built in, and some there it's just mandatory to capture this work. And there are, you know, a lot of other resources out there. I gave you 3 that are really good reads for you to learn a little bit more as well. And there are new roles out there to do this work. Community health workers are wonderful. They are your link between hospitals and the community resources out there. Some of our hospitals are now putting this position into place, and they are very successful. And they are actually the ones now meeting with patients that have these social needs. If you have not seen this new version of the CMS tool, this is a really great infographic. And on the back side of this, it lists all the Z codes, Z55 through 65. This can kind of help with your leadership to understand what we're all being required to do. So with that being said, this is how our journey has been, that turtle crossing the road. And I don't want to be discouraging, but I do want to let you know it is a marathon. It's not a race, and the journey will take some time. But there are a lot more resources out there now than there were 5 years ago, and a lot more people to help. So with that being said, I think I'm to this point. So Molly, anything?
I'm not seeing anything in the chat, but if anyone wants to ask questions, or I'll keep checking the chat box. Let us know what you have questions on. Thank you so much, Madeline. That was a great presentation. Very, very informative.
Thank you. I kind of rushed through some of it. There's so much to say.
A lot of information, that's true. All right, well, maybe while some of you think of questions, we have our post polling up right now. Similar questions to what you saw before. There are 4 questions to answer. I'm seeing no questions in the chat box, so I think that means you were very thorough, Madeline.
Thank you. It was very fast.
And someone asked in the chat about a copy of the presentation. Yes, you'll get a link to the recording, and then we'll send out a copy of our slides. It'll be posted publicly on our website as well within a few days. Well, before too many people jump off, thank you again, Madeline, for putting together this presentation. I know it was a topic a lot of us were really interested in. Thank you to participants as well for joining. Again, recording and slides will be available in a few business days. Please reach out if you have any questions on this topic or just general housekeeping things. We're happy to help. We'll be on a few minutes longer, but thank you again. And we got 100% participation in our post polls. That's really good.
Yeah, that's really good.
Don't see that often.
I was like, wow, looking at, I was like, oh man, I wish I could, when we do our presentations in the state, we just started doing this now.
Mhm.
More of those pre and post questions. And, we're like, oh, what are people going to say, and are they going to stay on to answer? So
Yep.
it's much better than sending a poll out or a survey out and trying to wrangle in all the results that come in.
I agree. Well, yeah, I'm grateful to everyone that responded.
Well, I'm going to go ahead and sign off now, but thank you so much for offering this opportunity to share and present. Um, I hope somebody went home with something new today anyway.
I think they did. It was good information, really good information for me too.
So good. All
Well, we
right.
appreciate you. Thank you. And
Thank
hope
you.
everyone has a good rest of
Bye-bye.
the week.